Um, this is going to be a talk that's a little bit like bringing coals to Newcastle, because I know all of you, as you so clearly showed me today, we started talking about cases, know a lot about Chiari. Residents and I had a good time discussing it, and Dr. Friedlander and I just discussed also the issue of Chiari's and all the different symptoms and issues that occur with them. So I'm going to talk a little bit about some of our background and how we, what we really do know about it. We're getting a lot more information with the Park Reed study, in which we've been looking at Chiari's, and I'm trying to understand more about them. But I guess what I'd like to do today is just maybe tickle your brain a little bit about what's real and what's kind of imagined. And so I'll start off with the usual there. I've got really no conflict of interest other than to say I have become a diehard Wolverine, and I know that can be difficult, but it's definitely part of my soul at this point. As we look at Chiari's, I think we have to understand that we are at a position in time now where the media and social forces are, in this particular area, influencing us a great deal. There are a considerable number of advocacy groups that are becoming part of the landscape of taking care of patients with Chiari's. And you can see that these groups have an enormous presence on the internet. And that presence is something which I think influences many of our patients. The number of symptoms that have been attributed to Chiari's are really dramatic. I mean, they are enormous. There are pretty much, if you open a textbook of medicine and read down the columns of the various chapters, at some point someone has probably written a chapter or a paper about some aspect of it involving Chiari's. And I think we have to, as physicians, understand that influence in our diagnosis and eventual decision tree about what we're going to do with patients. And so, it's one thing when we see a patient like this, and we understand that they've got a Chiari. I'm sorry, that little blue is
strategically located.
Strategically located, but this was a patient who presented with headaches. These headaches were usually associated around the time of her menstrual cycle. The headaches were made better with sleep, often preceded by flashing lights, made worse with bright lights and sounds. But the radiologist read this film as a patient with a Chiari malformation. What you can't quite see behind the blue right there is the suboccipital decompression that occurred and the multiloculated pseudomeningocele that occurred in this person, who then came to see us, and we needed to repair the pseudomeningocele. So the patient had 2 operations, and I would say that in most of my experience, the symptoms that they were displaying really represented migraines, and that I did not honestly think, particularly the CSF flow at the foramen magnum was normal, that this patient was somebody that I personally would have operated upon. But this is the thing that they are faced with, and why it becomes so difficult. When you hear that patients are suffering because we have failed to make the diagnosis, that patients say that they are been told that they're crazy. And I think this is where it becomes very difficult for us as physicians, trying to make the decision as to who are the patients that we should appropriately operate upon versus those of which it's merely an incidental finding and perhaps not even one that's worth describing as a Chiari. One of the things that I think has hurt all of us is the nomenclature that's been developed around what in fact is a Chiari. If you look at the symptomatology, really it's been dramatic. I mean, heat and cold intolerance, depression, hydrocephalus, pins and needles, balance problems, fatigue, headaches, cave pain, back pain. The numbers of symptoms are just enormous. And what I think is interesting also is that many patients assume that every ache and pain that they have is in some way related to the Chiari. And that becomes one of our problems. it's gotten to the point that it's so viewed and analyzed. There are now treatments for the veterinary part. And, there's the canine Chiari Institute. And to be honest, some parts of it, by virtue of the genetics of these animals, really do, in fact, represent something that perhaps can tell us a little bit about some of the CSF physiology that we're looking at. But we're at the point now where literally our pets are being diagnosed with Chiaris and requiring surgery. So if we look at the origin of Chiaris, I think the one thing that I can speak to now with pretty great assurance, what we term Chiaris is a whole group of problems. And we need to understand that the idea that there would be cerebellar ectopia, meaning the cerebellum is through the foramen magnum, can occur for lots of reasons. We know that, for example, in basilar pagination, we can see this. We can see it congenitally, and it's more of a traditional type of Chiari type 1. Those of us that do a lot of craniosynostosis operations, we see this in craniosynostosis, in which the cerebral vault, the cranial vault, doesn't quite meet the cerebral volume. And so patients that have bicoronal synostosis, patients that have lamboid synostosis, particularly, we can appreciate that. Patients that have problems in which their bone physiology is altered, we can see it in that. In patients that have venous abnormalities, and particularly in patients such as pseudotumor patients, or patients that have stenosis at the level of the internal jugular. Rarely we see it in patients who have associated tumors in which there can be, in fact, cerebellar ectopia by virtue of the fact that the tumor is causing pressure. Inflammation, patients that have significant inflammation either due to infection or some sort of vasculitis can have this as well. I have had patients who presented to me that had rather full posterior fosses and cerebellums without any single mass. The one you did a contrast study, what you saw was an enhancement of their folia of the cerebellum. And in fact, when biopsied, what you found out was that they had a diffuse either PDT or some other kind of tumor. So I really try to make sure that I get at least one study in which I have contrast, just to make sure I'm not missing something like that. But you can get fooled, and I think that understanding that the origin of the Chiari, the problem, may not be only related to the foramen magnum is important, and it's something that we really now, I think, appreciate, and that the term Chiari is used in a catch-all way, but really can often represent problems that have distinctly different origins and need to therefore be dealt with in different ways. When you look back at the initial origin of the word and how we started calling this a Chiari malformation, it used to be that there was a period of time in which we included Arnold in this. Well, we really appreciated that Chiari was in fact the one that really did most of the work in this, and that Arnold was the professor, and therefore was included in it. I think we now focus much more on Chiari malformations. So if you look at the initial analysis that they did when they were looking at Chiaris, it wasn't in fact even in patients that had a true Chiari. The majority of their patients in fact had hydrocephalus, and 2 of them had tumors. So the initial description of it wasn't even for patients that had a true cerebellar ectopia. It was in patients that in fact had mass lesions associated with it, and that it really wasn't representative of something which was congenital. The initial analysis of Chiaris back in 1978 really was trying to look to see if there was a way in which you could diagnose them more effectively. And remember, back before MRI scans, it was usually based on CT findings, looking for, with, let's say, a myelogram, the location of the cerebellar tonsil, how far down they went, and then looking for that dilation of the spinal cord, because many of the patients were being picked up later in life, meaning in their 30s, having had a Chiari with significant syringomyelia. We've shifted that curve more towards the 20s, primarily because we're getting MRI scans, and so we're picking people up long before their syrinxes become problematic. If we look back at the initial studies that were done, this was back in 1984 at MRI scanning, they really were looking at a very small group of patients in which they incidentally discovered the cerebellar ectopia. This is one of the very starting point of MRI scanning. And what they saw, again, that the majority of patients in that very small study where they talked about them, they had low cerebellar tonsils, but they also had hydrocephalus associated. And I would say to you that that was a secondary Chiari associated with a different problem than is the traditional Chiari, in which there is no hydrocephalus and in which there's just merely cerebellar ectopia. And why did we get to the point of this 5 millimeter rule? I don't know about you all, but for me, it's the bane of my existence. Because every patient comes in and says to me, is it 7 millimeters this year, or is it 8 millimeters? Is it 6 millimeters? And I want to say, and I try to explain to them how you position yourself in the MRI scanner can make it go, up and down a couple of millimeters. But this was something that when Barker looked at this and brought this forth, he was looking at a very limited number of patients. If you look at the numbers, they're really quite small. That he had normal patients, only 25 in his group that he declared as Chiaris. If you look at the specificity, you look at the sensitivity, again, a small number, and the sensitivity was also something which was really not all that great. It was, they thought about it and said, well, at 5 millimeters, that's where it's the most important and most relevant. And I think we realize now that that really is not the best way of looking at it. And in fact, we've made it even more complicated for ourselves when Jerry Oakes started talking about the Chiari 0, meaning that it was, a tight frame and magnum, but really no cerebellar ectopia. The asymptomatic, Chiari 1 patient, the patient who existed with findings of cerebellar ectopia all the way down even to the arch of C1, but with no symptoms. And I think what we now understand is that at best, the use of the 5 millimeter rule is important if we're going to try to understand a set of patients where we can at least define where the cerebellum tonsils exist. Again, look at all these different terms for it too. Herniation, descent, ectopia, position. And I think all these different terms are valuable, but they're mostly useful for communicating with each other as to our findings. And I would also suggest to you that the roundness of the cerebellum and how they look becomes an important part of all of our assessments. All of you, I'm sure, have to deal with this. I know I do. Read these reports. They always talk about the fact that there is, when they use the word herniation, that just drives me crazy, because what happens is the families read these reports and they're coming, particularly the parents, calling you up and saying, oh, you got to do something, this is really important. And I would say to you that as you look at this, one of the things that's important to understand is that we have now learned through all of our findings that the position of the tonsils becomes important, but what's also important is the shape of them and the associated symptoms that can be seen. So again, this low-lying cerebellum, they often will say that there is something that they should be evaluated by neurosurgery. And I always marvel at the fact that our radiologists are providing us with many of these referrals. Again, the tonsillar ectopia, again, another way of putting it and phrasing it. And that tonsillar ectopia, again, they'll often evaluations that they can be the cause of the headaches, they can be the cause of neck pain, and are telling our patients point blank that they think they need surgery. That's a problem. So if we look at diagnoses that are occurring, all of us are now making Chiari diagnoses, or seeing more patients with Chiaris as we do more and more MRI scans, more studies. But we're not alone in this. If you do more studies, you're going to find more issues. They're picking up more incidental findings of breast cancer by virtue of the imaging that's done, thyroid, lumbar disc disease, small aneurysms, renal cysts. And so as we do more and more studies, we begin to find more and more patients. And so there's now, I think appropriately, even an assessment as to who should be getting an MRI scan. Are patients that have, is every patient that should get a headache getting an MRI scan? Well, I can tell you that in Canada and other places where there is a different form of organized medicine, they ask that question regularly. And one of the things that they talk about is patients who have had frequent and recurrent headaches for most of their life. Those are probably not necessarily people that need imaging, as long as there are no neurologic findings. We are diagnosing Chiaris at an increasing rate. That increasing rate is also reflective of the fact we've got more and more patients that are being seen with Chiari's on their MRI scan. But who is having surgery? And if you look at it, believe it or not, the numbers, I know you're shocked by this, are going up along with the number of MRIs that we're ordering. So it seems as if the more we order our studies, the more we're beginning to see this. And there are socioeconomic factors that play into this. So if you look at the pediatric population, again, a fair number of those patients are in wealthy and more affluent families, and I would suggest that's probably also reflective of the fact that they are getting more studies. In the adult population, that's certainly the case as well. And so I think if you see this, one of the things that you can appreciate is that it's not always a great thing to be getting all these imaging studies that we get, because we then have to deal with the consequences of findings and trying to understand where those findings are important and where they're relevant. The number of Chiari patients that we see, we look, it's a far greater number related to women versus men. And if you look at you get a detailed history, many of these are associated with changes in the menstrual cycle, all of which, again, are reflective of the fact that headaches and other pains associated with even hormonal changes can be significant. And I think that's important as well. There's also geographic variation, and you can't tell me that the differences in humans based in northern, southern, western, eastern are reflective of real changes in the Chiari, but this is reflective of who gets operated on. And that's reflective, again, of probably advocacy groups, but also surgeons and their surgical approaches to those problems. And so the fact that there are differences in that they're seen in the greatest areas where there's the largest number of neurosurgeons is not actually something that is totally shocking. So there are two variables. We see the patient advocacy groups and we see neurosurgery practices. And I would ask you to think about that as you're looking at your own patients and trying to make decisions about who in fact should get a Chiari decompression. So how do we find the disease? Is it based on clinical findings or is it based on imaging? So you can see a patient here who's got a significant syrinx cavity, and that patient has obviously tonsillar. You see another patient here who has just the tonsillar, but no hydrocephalus. And trying to make a decision, no syrinx cavity, trying to make a decision between these two patients, who you're going to operate on is one where I do think that symptomatology becomes extremely important, and recognition of what the syrinx can in fact mean. So if you look at it in the United States, we do almost more imaging than anybody else. We are among world leaders in our use of imaging in patients. And I think it's also a reflection of why we have so many patients that we're performing Chiari decompressions on. I don't think that necessarily the disease pattern and the operations that are being done here reflect a difference in population of the United States compared to Europe, or compared to Australia, or compared to Canada or France. I think all of this is reflective of the fact that we're diagnosing it more, we've got stronger advocacy groups, and as such, it's actually influencing our practice patterns. So here, if you look at the number of patients and in terms of the number of people that are getting operated on, the number is exactly reflective of the number of MRI scans that we're doing. And so the two things parallel each other quite effectively. So is Chiari a rare disease? I guess when I was training, I thought it was, and maybe that was just because we didn't see it as much, we didn't have the right imaging. Certainly, I think we began to appreciate it more and more as MRI scans became more common. But I can tell you that now, even the NIH has changed its opinion about it, and it's no longer classified as a rare disease. And so we have changed even the classification of Chiari's by the federal government, just simply based on the volume of patients that are now receiving surgery. And if you look at biologic patterns, much of our world is a bell-shaped curve, and the norm sits in the middle, but there's a little bit on either end, and that's certainly true for Chiari's. And so this idea that 5 millimeters is the cutoff is reflective of something which is not necessarily physiologic, because we do see a wide range of tonsillar location in patients for whom there is no symptomatology. And we need to be careful about that because there's a distribution of the tonsils which varies with age. So initially it's a little bit lower in young children, and then it tends to ascend. The point at which the tonsils are the lowest is usually during the time that we see the most symptomatic patients, which is in the teens and 20s. And certainly we know that by the time you hit 30, your tonsils are starting to ascend, probably because of volume loss. So as each of you are listening to me today, you're losing brain cells, and in fact, your tonsils are probably slowly but irreversibly going north. And patients in their 70s and 80s, for certain, have very little chance of presenting with significant Chiari symptoms. So again, if you look at the tonsillar distribution over time, it goes down up until you're about your 20s, which means that that's the time at which you probably have the greatest chance of being symptomatic, and it certainly fits with the population as we see them. But then obviously your tonsils begin to rise over that, and that's again reflective of volume losses of the brain itself. So
why do you think they drop? Like, over that period
I think
of time?
that's the volume size of the brain, which is increasing usually until you're about 13 to 14. And then after that, you get the thickness of the skull itself, which is also getting bigger. And so I think the two things in combination, you then begin to see the natural. I think what this probably suggests is that what you're seeing over time is an aging process that starts probably in the 20s to 30s, where the brain is actually probably decreasing in size a bit. So I hate to tell you, but we're all getting old very quickly. So does tonsillar position really matter? Are people with lower tonsils more likely to have problems? And I think this becomes an important question that we're only beginning to understand. And so if you look at it, you can see that the 5 millimeters, probably not, but as you start getting lower and lower, the percentage of patients that become symptomatic goes up. And so clearly once you start getting past 10 millimeters, the percentage gets quite higher. And so I think that's an important consideration, but by no means is the differences of 5 to 7, 4 to 6, that kind of thing significant, at least according to the data that we were looking at, again, looking at optimum data and looking at the combination of things. There is also an interesting phenomenon that the risk factors for association with the syrinx cavity go up, and that is the chances of having a syrinx are increased once you start seeing cerebellar tonsils past about 10 to 11 millimeters. And the chances of having a syrinx associated with your Chiari are much higher. The number of patients that we see clearly is the greatest at that 5 to 7 millimeters, but the number of patients that have syrinxes are with tonsils that are considerably lower than that. So if we now look at the 21st century data, some of the work from the Park-Reeves study, which I know all of you were involved with as well, you can appreciate now that this rule about 5 millimeters is one that was kind of arbitrary, based on a pretty small group, but probably not something that's going to be beneficial in the long term. So now we've got to start looking at other things. We know that tonsillar precision is really not that specific, and that the specificity at 5 millimeters is really not that great. So what are some of the other things that we can look at? Well, we know it gets greater when you get past 10 millimeters, and certainly much greater once you get beyond that. 15 millimeters, it's approaching really almost 90%. So that tells us that the really, really low cerebral tonsils absolutely are going to have a very high chance of being symptomatic. Okay, what else does it mean? Well, I think 5 millimeters shouldn't be considered a cutoff point. And I think I'm trying to work with our radiologists in our institution, even across the board, to understand that, because I don't think the 5 millimeter rule helps us in our patient population, because it brings many people to the door thinking that surgery is their only option, when in fact it is not by any means a hard, fast correlation. I also think that there's probably the low end of what's within the normal distribution based on just normal parameters of the bell-shaped curve. And the lower the tonsillar position, the more likely you are to be symptomatic, and also the more likely you are to have associated syrinx. Finally, of course, age does in fact matter in all of these things. What about other anatomic issues? What about things like measuring the posterior volume? I really thought that posterior fossa volume was something that was going to prove to be really helpful. And so we looked at a variety of things, tentorial length, we looked at basilar impression, we looked at all these things to try to associate it. We actually had folks, but now with AI, we could actually do volumetric analysis really extensively of the posterior fossa. And when we looked at it, we thought that these were the areas that seemed to correlate the most with cerebellar ectopia. But when we did this, we looked at 102 Chiari patients. We looked at, they were matched by age, by gender, also matched as much as we could by tonsillar morphology. And we did a really careful analysis of this, trying to look at everything from basilar invagination, tentorial length, all of these things. And, did the posterior fossa volumes differ between our symptomatic Chiaris that received surgery and those that didn't? And in fact, there really wasn't much of a difference. And so this idea that it's a really small posterior fossa volume doesn't exactly correlate with what we found, at least in our work. What it did correlate with was, again, the length of the cerebellar tonsils and where they were, but the volume of the posterior fossa wasn't necessarily correlated with the symptomatic Chiari. So if we don't have great objective things, like the measurement of the posterior fossa volume, like the measurement of where the cerebellar tonsils are, at least, what is it really then, what's important? We're kind of left with things that are a little more inferred. What's a pointed tonsil? What does that look like? Are the tonsils deforming the brainstem? Is there CSF flow impairment? Is there crowding of the craniocervical junction? Or do we have to rely a lot on clinical diagnosis? I can tell you that I was one of the people that really put forward CSF flow at the foramen magnum and Cine MRI scan back in the early 90s as something that needed to be considered quite carefully. And I think it's a valuable importance for us to look at. But as I was telling the residents earlier today, there are patients who have marked improvement, who have improvement in their symptoms, improvement in their syrinx cavity, who still have wildly abnormal CSF flow on Cine MRI scan. I think the one thing I've learned from Cine MRIs is that in patients who have significant symptomatology, like headaches, like paresthesias, like a variety of things, who have normal CSF flow, I'm probably not going to make them better with an operation. So normal CSF flow in a patient really does suggest that that's perhaps not the patient for us to be operating on. And other means are going to be necessary for treating their headaches, which are probably among the most common aspects of their symptomatology. So we need to have better criteria to differentiate symptomatic disease from incidental findings. And, we don't want to get ourselves into a situation where we simply correlate one thing and make it a generalized phenomenon. It needs to be meaningful, we need to have it be measurable, and we need to have it be reliable among a variety of raters. And I don't think we have that yet. And so I'm hoping we're going to see more and more data out of the Mark Reeves study, but I also know that symptoms become very important for clinical indications. And I will tell you right now that the most common symptom for patients with Chiaris, which I hope all of you realize, is headaches. And so when there are common findings like Chiaris and common symptoms like headaches, we're left in a very difficult situation. We're left trying to ascertain which headaches are important. In the United States, up to 10% of children will experience migraines. Again, greater in the female population. 20% of adolescents have headaches at least one or more times each week, and 6% report headaches several times a week, or in fact every day. And that's just based on basic pediatric practice. The American Academy of Neurology says that neuroimaging is recommended in patients who have had headaches that are severe or significant, of less than a month duration, have any kind of abnormal neurologic examination, have no family history of migraines, and who have seizures. They're not recommended in children who have just recurrent headaches and a normal neurologic exam. Try telling that to the mom of a kid who is home from school for 2 weeks at a time and not going to school. Those people are going to wind up getting MRI scans, and the pediatricians, I think, get worn down, frankly. They're not going to bite at a certain point because they're always worried that they have missed something. I also have to say that I think it's complicated by the fact that the advocacy groups are so vocal that if you Google the word headache, you will find a lot of sites online that will talk about Chiari malformations and how significant they are, and how you have to be the quote unquote advocate for the patient because the doctors don't understand. This is problematic. It's something we all have to face. I think it's something we have to be not only cognizant of, but actually think about as we're starting to make the decision tree for our own patients. And again, the headaches that are attributed to Chiari, they're usually fairly specific in the sense that they're often described as posterior headaches, usually associated with coughing, sneezing, or Valsalva maneuver. But they can be associated with other aspects of it as well, and there's often a blended picture. Now, a migraine, at least according to my neurology colleagues, and it's one that I kind of believe, there's usually a family-associated history of them. Often there's lights or other visual phenomena before they get the headaches. It can be associated with nausea. They're made better with sleep, made worse with bright lights or bright sounds. But Chiari's can often blend into this. And so you have some patients who, when they're active, they get the headache, but they find that when they go to sleep, it gets better because they stop the activity. And one of the things I try to counsel all of my patients where I do a Chiari decompression is that, pain is actually a sign of life, and that most people will have some pain at some point in their life and have headaches. And to assume that all headaches are going to be gone after one does a Chiari decompression is just incorrect. And so I think you have to really stay aware of that. And, I think Jerry Oakes would say that when you're dealing with a patient with a Chiari, you should, quote unquote, be able to reproduce their headaches with straining or stressing in your office. I don't always agree with that because I'm not sure the activities can be fairly specific. I mean, I've seen the kids that, when they're blowing through a horn, that's the thing that gives them the headaches. Or the kid that's playing, and they've got to be aggressively playing to be able to develop the headaches. But I must admit that I kind of cheat, and I try to have people in the office do something like either do push-ups against the wall or try to lift the exam table, which is heavy, just to see if that can reproduce their headaches. But I'm not certain that every single patient can necessarily produce them in the clinic like it's been suggested. But I do also think that there are some aspects to it which are more typical. Those with the Valsalva maneuver, those in which the pain is primarily occipital, those that are brought on by coughing, often can be something that are associated with Chiari. The other thing that I think is true about the majority of Chiari patients is the phenomena of the headaches lasting, meaning that they don't go on for 5-6 days as some of these patients that are migrants and having a migrainous attack. So I think that the one thing that is also important to realize is that the location for the headache is something which is often posterior, but can be in lots of, it can radiate to other places, and that's an important aspect of the symptomatology that needs to be considered. So headaches in the Chiari patient, is it typical? Well, I think that Jerry Oakes' rule is something I do believe in, but I also think that it's important to distinguish them from migraines. Again, we just talked about all those associated symptoms. And the other thing, and this is also true, in general, a headache is not going to kill you, right? And so you've got to figure out which are the ones that are life-altering and refractory to other standards of treatment, and whether or not you're going to proceed with the associated risks of a Chiari, admittedly small but still present, of doing an operation on a patient. And I think that becomes one of the things that certainly needs to come into your assessment of things. So understanding the headaches and understanding the degree to which they are life-altering for patients is an important one. So headaches in Chiari patients, I think the ones that are particularly mild, I'm less concerned about. I think the severe and atypical ones, I'm very concerned about, but I'm going to evaluate pretty carefully. I think that the ones that are mild and typical, I'm not going to be doing anything about. The ones that are severe and typical, I'm certainly going to consider. The severe and atypical, one of the things I will do is I will try to use every method possible of treating them before I will consider an operation. And I think that becomes part of the understanding of how patients need to realize that an operation is not necessarily a cure-all for many of their problems. Again, I just go back to the fact that Chiari I symptomatology is extensive. It involves pretty much every organ that you can imagine and is reflective of many, many, many subtypes of things. And I think we need to begin to understand a lot more about cerebellar physiology to know how much is really influenced by it. I know you're doing a very interesting study, and Dr. Klenke presented this about memory and cognitive abilities, but I also think that one needs to recognize that there are associated things that can occur, like overlays of what medications you're taking, et cetera, that can influence the apparent relief that's achieved after a decompression. Again, placebo effect is not a small one, and we have to recognize that. So what about a syrinx cavity? I was fascinated. This is how I got interested in Chiari's to begin with. I was a chief resident operating on a patient that had a Chiari with a large syrinx. And I remember trying to understand, why would something at the foramen magnum create a syrinx cavity? Why would it do that? We now know that the origin of the syrinx cavity is reflective of the fact that there can be, at times, flow at the foramen magnum, which is impeded by the cerebellar tonsils. And so what are the forces that are placed in the spinal cord? And if there's no communication between the fourth ventricle and the central canal, how in fact does the syrinx start? And there was really a good series of studies that were done at NIH. I started them, and we worked together with Ed Oldfield and the folks at NIH. If you look at syrinx development, the brain will expand during systole, and in normal patients, CSF goes from the basilar cisterns to the upper spinal cord. But in Chiari patients, you actually see this plug at the foramen magnum. And as a result, one of the things you can see is that the cerebellar tonsils, in fact, act as a piston and can partially isolate spinal CSF spaces. And with systolic pressure waves, produce CSF, which acts literally upon the spinal cord, pressing into it. You can see this in not only the radiologic analysis that's done, but you can even do dye studies, which can show that the dye continues from the subarachnoid spaces through the via cava into the spinal cord itself. And so we know that this can, in fact, act as a pistoning effort. So it's not just any syrinx either. This is a clear example of someone who's got tonsillar atopia and also has a Chiari with a significant syrinx. What you can appreciate is that in other patients, that syrinx can be significant along with the Chiari, but for some, you can see a patient in whom there is really and truly not much of a syrinx, but there's an associated Chiari, and now you've got to figure out whether or not the syrinx cavity is something which needs to be operated upon. And we've got a great picture of someone's ear there. And then you see the one that's just kind of been slightly dilated central canal. And I think those are all very different phenomenon. And so the one thing that we did begin to find is that the syrinx cavity, and we looked at a series of our patients radiographically, the patients that in fact had Chiari malformation in the syrinx cavity, you could appreciate that the syrinx cavity was located primarily in the cervical area, and other phenomena like tethered cord, like post-traumatic, located more distally in the cord. So we actually wrote a paper looking at this and talked about the fact that the syrinx cavities that were located in the cervical area were the ones that really seemed to be associated with Chiari, and that it was the more distal ones that were associated with other phenomena. So if you look at the ones that are associated with spinal dysraphism or tethered cord, very different location, whereas the ones that are for Chiari malformations are really in the cervical area. And I think that becomes important when you're dealing with a patient who may have a small syrinx, let's say in the low thoracic area, or just a very tiny, thinly dilated central canal, and they seem to have a Chiari, and then they have typical idiopathic scoliosis, particularly young women in their teen years. I don't think the Chiari is the thing that's causing them to have a syrinx cavity, and the existence of some cerebellar tonsillar atopia without a significant syrinx in the cervical area really is associated with something that is going to be improved upon with the Chiari decompression. So again, it tends to be in the cervical area. The others tend to be more distally located, such as associated with a tethered cord or spinal dysraphism. This is just looking from that study where we saw the associated syrinxes in patients with Chiari. Again, much more of them in the cervical area, and really much more suggestive that those are the ones that are important to consider as being associated with Chiari's, rather than across the whole spinal cord, where the more distal ones are associated with spinal dysraphism. So, is Chiari always associated with the syrinx? Yes, but there are exceptions. Not all Chiari patients have a syrinx, and certainly not all syrinx patients have Chiari, and not all patients with Chiari and syrinx, particularly in the more distal areas, have that syrinx as a caused by the Chiari and will necessarily improve with the Chiari decompression. And I think that's important to consider, particularly when you see patients that are either relatively asymptomatic, but have perhaps a more distal syrinx associated with it. So again, not just any syrinx. I think these patients that have just a slight enlargement of their central canal are not really ones that are going to be associated with improvement and or significant Chiari malformations. So lastly, we look at scoliosis. We see some patients that have pretty significant scoliosis and just a little bit in the way of a Chiari, such as you see here, a little bit of tonsillar ectopia. And when you look at those patients that have got a significant syrinx, then that is something that you certainly would want to look at and see, because I think that a cervical syrinx associated with a Chiari in a patient with scoliosis, there's a good chance that those things will improve with a Chiari decompression. And so when we looked at scoliosis, one of the things that we did appreciate was the fact that Chiaris themselves can be associated with the syrinx, but the syrinx must be in the cervical area for it to have significant consequence for the patient. And so as we looked at the specificity and looked at our p-values, that was certainly true, that in patients that had a Chiari 1 with a cervical syrinx, it was much more important. So you look at these patients, here's a patient with a Chiari, with a syrinx, with scoliosis. I think that that's absolutely a clear line of sight connection between them. Those patients that have merely the Chiari and a syrinx, but no, that have a Chiari, scoliosis, and no syrinx, those patients are less likely to be able with a Chiari decompression. And in fact, I don't generally offer that as something that will be done unless there is some form of syrinx associated with it. And so, surgical indications. The anatomic findings of Chiari patients can usually be pretty significant with severe and classic tussin-type headaches. The anatomic findings of a Chiari malformation with a large cervical syrinx are important to consider as you're thinking about whether or not the patient needs surgery. And scoliosis, I believe, is a surgical indicator only if there's an associated Chiari malformation and a large cervical syrinx. One of the questions that was asked early on in all of this is about stability, and I think we've now got that data pretty clear that if you don't have instability of your cervical spine before you've done your Chiari decompression, you're unlikely to develop it unless you just start taking more than the arch of C1. Once you start going into the muscles of C2 or the arch of C2, you have a much greater chance of, in fact, having instability. And so I personally, in my own operative field, tend to really try to avoid C2 as much as possible and tease up the tonsils rather than do more bony work. What about tethered cord? I'm sort of tired of hearing about it all the time because there's, I know, a phenomenon, particularly in one particularly Chiari Institute in New York City, where all the patients get it done tethering along with a Chiari decompression, along with a cervical fusion. I can honestly say that, tethered cords do occur in the patient population, but it's fairly rare. Chiaris obviously occur in the patient population, and there's a small percentage of patients who will clearly overlap. But I think that for most patients, the association between a Chiari and a tethered cord is extraordinarily thin. And so I would say that tethered cord does occur in patients with Chiari, but it occurs at a rate that's far greater than the average population. No, I don't think that's true. I think that, in fact, it's fairly unusual for the two phenomena to be related to each other. And there's currently no good evidence to suggest that performing a large number of untethering operations on Chiari patients with normal level position conuses is going to benefit them. And I think this phenomenon of assuming that because there's a Chiari, there must be a tethered cord is just, I don't think there's any evidence to support that at this point. The other thing to realize is that Chiaris can in fact get better, and the natural history of asymptomatic or minimally symptomatic Chiaris has been shown in multiple studies now that the patients, in fact, a small percentage of them will get worse, a small percentage of them will in fact get better, and the majority, the level of tonsillar ectopia does not significantly change. And in fact, what we have seen is that for some patients, the Chiaris in fact improve over time. And our latest study, which was the study that was done with Jen Strawley, who's now at Washington University, showed that in a large number of patients, we could in fact see that there were several patients who in fact improved and did not eventually require any kind of intervention. A small percentage of the group that had Chiaris but were not operated on and had no symptoms eventually developed symptoms requiring a Chiari decompression, and that there was also a small group, but a real group, that eventually developed Syrinxes, which also were something that caused us to want to operate on them. But the majority didn't, and so for the majority of patients, this is a patient that in fact, that's what they looked like at the time we initially diagnosed them. They only had headaches, had no other symptoms. The Syrinx cavity, you don't see it well there, but it really disappeared and nothing changed in terms of their appearance. I've seen some people who actually went from having significant Chiari, and over time, that is what they look like. Their cerebellar tonsils, in fact, rose over time. So I think you really do need to understand what the symptoms are that the patient is having. This patient happened to have had the Chiari diagnosed after a minor soccer injury. So the natural history of Chiaris, we, as I said before, a small percentage, about 10 to 15%, will get worse over time. A small percentage will get better, more like 7 to 10%, and then the majority stay with their tonsillar position at the same time. So there is no consensus about how to define a Chiari. The 5 millimeter rule clearly has some problems. The symptomatic Chiari is rare, but the asymptomatic Chiari is actually pretty common and something we're seeing an increasing volume on. The symptoms and Syrinx cavities are more likely with increasingly lower position of the cerebellar tonsils. And patients with typical or severe symptoms will benefit from surgery in most cases, but that means that the selection needs to be careful because one can operate on a large number of patients for whom there will not be improvement, and they all expose all of those patients to possible risks. The natural history of asymptomatic patients or minimally symptomatic patients is actually reasonably good and are really not something where I do think they need follow-up, but I don't think one needs to feel great fear. So who's driving the agenda? It's really important for all of us to recognize the extent to which advocacy groups can not only influence our decisions, but influence a patient's opinion about what our decisions are. And we need to be aware of that and stay in tune with it. It's actually one of the reasons why getting involved with some of these advocacy groups is important. Although we find it annoying, it's a way in which we can help them make good decisions. So as we, as physicians, are educators, it becomes important for us to help people understand a little bit about why we're doing things, and really we need to be in teaching our residents thinking about why they choose to do certain operations and why certain things are important. I'm going to just show a couple of pictures here. This is a case example of a patient with a Chiari that had a large Syrinx. That I have no, that's an operation that I think is appropriate. And I will sometimes even operate on some patients that are minimally symptomatic with this because I worry about the long-term symptoms from a Syrinx. But another patient that has just this phenomenon of a dilated central canal and little else in the way of symptomatology and this level of Chiari, I'm not apt to operate on because I understand that Syrinx cavity I may follow it, but I'm not necessarily going to immediately jump to thinking that that dilated central canal is something that requires surgery. And certainly when you see a syrinx cavity more distal in the canal, again, I don't view those as being involved with it. Certain ideas about, Chiari's, clearly, it's like many things. One can develop opinions, and I'm trying really hard. I've been working with Cormac Moore and Hugh Gardner. We've been working for many years in trying to write as many of these things up as we go through our own case studies, et cetera. These are some of the things that obviously I believe in. My partners and I have really come to this conclusion. We really do believe, and I think the paper that was most recently written about opening the dura versus not opening the dura, I do believe there's no way that you can absolutely guarantee outflow from the fourth ventricle without opening the dura. And often the syrinx cavity is associated with patients that may have a web or some other phenomena at the level of the foramen, the level of the fourth ventricle that needs to be addressed. I really hate syrinx shunts. I hate any kind of mechanical device or any device that's going to be able to be either dislodged or malfunction. And so I truly try to address syrinx cavities at the level of the foramen magnum if they're cervical syrinxes. Different if they're more distally in the canal or associated with other problems like previous trauma or a tethered cord or something like that. I don't think we understand CSF physiology, and I was one of the people who really pushed to looking at Syne. I think that we've looked at it in many different ways at our institution and have come up with conflicting outcomes about its significance. I do recommend a Chiari decompression in an asymptomatic with a very large cervical syrinx because I do worry about symptomatology, and I have found that once one gets some of the symptoms associated with significant cervical syrinxes, like burning dysesthesias in the hands, they can be difficult to handle even after a syrinx has been adequately decompressed through a Chiari decompression. And the other thing is we did a very extensive study looking at sports, and we found that really and truly the incidence of abnormalities or having problems in patients with Chiari's was no greater than the average population. So I rarely restrict sports participation for Chiari patients that are not selected for surgery because we just have not seen the complications associated with that as actually had been previously reported. So I thank all of you for listening, and I hope this was at least a little bit of a thought-provoking analysis of Chiari's, because I do think that the ability to diagnose and treat them is something that all of us has the ability to do, but the hardest thing is to try to decide who is the right patient to in fact receive surgery. So thank you for your attention, and I'll be happy to take some questions.